Shan's going to talk to us today about her dissertation. Shan is a PharmD from the University of Pittsburgh. She did a residency at the University of Maryland. She worked in the Kaiser system for a number of years, came here as the Takeda Medication Adherence Fellow, is now a PhD candidate in our program. She got the first draft of her paper, paper one for her dissertation, done. So she's going to set a land speed record with which she gets through this program. Today she's going to talk to us about the first two aims of her dissertation, right? Or the first aim?
1B.
Aim 1B.
Make it short. All right, well, thank you for that very kind introduction. I think that set a little bit of too much expectations. No, I'm just kidding. So today I'm happy to present my presentation, which is going to be focused on the use of second-generation antipsychotics and adherence and persistence to oral anti-diabetic therapy in patients with depression and diabetes. So I would like to first give special thanks to my committee members, Dr. Lee, who is my dissertation chair, Dr. Liao, Dr. Schumacher, Dr. Touchette, Dr. Kim, and Dr. Caleb. So thank you. And I thought that a lot of you were present at my proposal hearing, so it's probably good to start with a patient case to talk through some of the complexities of this issue. So for the next 40 minutes or so, I want you to think in the shoes of either JR, a 54-year-old Caucasian female, or her primary care physician, Dr. Smith. So today we're at JR comes in with a chief complaint that she's still feeling a little down. She has a history of type 2 diabetes, major depressive disorder, dyslipidemia, and hypertension. She's on a slew of medications for all these conditions. Most recent labs, her hemoglobin A1C is a little high, not too bad. Lipid panel looks normal, a little bit of a low HDL. Vitals are normal. She is obese and with central obesity. Turns out that JR is not alone. We know that about 1 in 5 patients with type 2 diabetes have depression, and patients with comorbid depression, diabetes, have poor clinical outcomes, and this can manifest in worse self-care and medication non-adherence, poor glycemic control, earlier onset of complications, as well as a higher risk of mortality. What we know is that there's probably a bidirectional adverse interaction between depression and diabetes, where the inadequate response to depression treatment can lead to poor diabetes control, and the reverse is also true. So poor diabetes control can lead to inadequate response to depression treatment. So for a patient like JR, treatment goals should be aimed at not only resolution of depression symptoms, as well as maintenance of depression control for optimal patient outcomes. However, we also know that depression is quite difficult to treat. We think that about 1 in 2 patients are unable to achieve clinical remission with their initial antidepressant, and 1 in 3 are unable to achieve even just a 50% reduction in symptoms. So in clinical practice, patients often have to cycle through many therapies before they find one that works for them. However, the likelihood of achieving response really declines with each subsequent trial. And by 4th antidepressant, only about 13% of patients are able to achieve remission. So what is JR's depression treatment history? She is currently taking venlafaxine, which is a serotonin norepinephrine reuptake inhibitor. She's been on it for 8 weeks. She says she's feeling a little better, but not completely. And she's very adherent. She says, I haven't missed a pill. So what is her treatment history? It turns out that this is her 3rd antidepressant. She started out with sertraline, which is a selective serotonin reuptake inhibitor. She took it for 3 weeks, but she had some side effects. She was switched to escitalopram, another SSRI. She was on it for up to 8 weeks, and she didn't have a good response. Prior to that, she was on cognitive behavioral therapy. So for someone like this, what are her options? We can try another antidepressant, so we can switch, or we can add a second depression therapy, and this is called adjunctive therapy. When it comes to adjunctive therapy, we can add a second antidepressant. For example, bupropion, mirtazapine, or tricyclic antidepressant, TCA. Or we can add a non-antidepressant drug, and this is called augmentation therapy. And some of the examples are second-generation antipsychotics, lithium, and thyroid hormone. Today I'm going to focus on second-generation antipsychotics, which I'll call SGAs for the remainder of this talk. All right, so JR asked, I saw an ad for Abilify or aripiprazole, which is a type of SGA. Might adding it to my antidepressant help? I heard it works as early as 1 to 2 weeks. It turns out that she might not be the only one. There's been increasing use of SGAs for non-psychotic depression, according to the National Ambulatory Care Medical Survey, National Ambulatory Medical Care Survey. About 1 in every 8 outpatient non-psychotic depression visits included an SGA from 2009 to 2010. It turns out that SGA use was about 2 times higher in patients with comorbid diabetes, hyperglycemia, or cardiovascular disease. So what do we know about these drugs? It actually has the most consistent clinical trial evidence for adjunctive therapy. It has a faster onset of action compared to using antidepressant alone, and it's the only class of drugs that's FDA approved for this indication. However, these drugs are also associated with some serious side effects. We know there's a risk of weight gain, dyslipidemia, hyperglycemia, and a risk of diabetes. And this highest risk period is thought to be between the first 6 to 12 months of therapy. So, the American Psychiatric Association recommends carefully weighing the benefits and harms of SGA augmentation with consideration of metabolic complications. So, should JR use Abilify? What are her risks and benefits? So, her benefits is, her depression could get better, and her risks are the weight gain and hyperglycemia associated with these SGAs may potentially cause her diabetes to get worse. Turns out it's not quite so simple. What we think is that we know that certain antidepressant therapies also cause weight gain and also have been implicated as a risk factor for causing diabetes. However, the use of antidepressants in a pre-existing diabetes population has also been associated with improved glycemic control. And the hypothesized mechanism behind this is through improved self-care and adherence to medications. Okay, so perhaps if we give JR Abilify, her depression gets better. Maybe we'll see an improved diabetes self-care and adherence to diabetes medications, which possibly could negate or even nullify some of the effects of hyperglycemia in diabetes. So Dr. Smith might be thinking of these questions in her head. From clinical trials, I know that SGAs work for depression, but how might starting this drug impact JR's diabetes? If JR's depression improves with the SGA, would it improve her adherence to her medications, possibly negating any direct detrimental effect of SGAs on glycemic control? And perhaps the $1,000 question, can I safely treat her depression with SGA without compromising her diabetes? Or should I try adding or switching to another therapy? It turns out that we don't really have answers to our questions. There are several research gaps when we look at SGAs and diabetes. Most studies have focused on new onset diabetes. Much less is known about the influence of SGAs on pre-existing diabetes, with some conflicting evidence. Some studies have found an increased risk of hypo and hyperglycemic hospitalizations, while other studies have found that use of these drugs may decrease mortality and decrease the onset of diabetic complications. Furthermore, most of these studies were focusing on patients with schizophrenia or bipolar disorder, which is what these drugs were traditionally used for. And there's no specific studies in the MDD and pre-existing diabetes population. So if we go back to Dr. Smith's questions, how might starting SGA impact JR's adherence to your diabetes medications? There is one study that has evaluated the impact of antipsychotic use on adherence and persistence to diabetes therapy. This was done in a Texas Medicaid population, where they found that antipsychotic use was associated with improved adherence and persistence to oral anti-diabetic therapy, or OAD, compared to no use. However, this may or may not apply to JR. In the study, OAD initiation was in an antipsychotic user group while JR had pre-existing diabetes. Many probably had these other psychotic disorders while JR has MDD. The study showed pooled results for first-generation antipsychotics and SGAs, but first-generation antipsychotics are not used to treat MDD in a non-active comparator group, while JR probably has other treatment options. So the specific aim of this study is to compare adherence and persistence to OAD therapy between SGA initiators versus initiators of alternative depression medications in the population of adults 18 to 64 years with treatment-experienced MDD and type 2 diabetes. So they had to have past use of either a selective serotonin reuptake inhibitor or selective norepinephrine reuptake inhibitor, and they had to be OAD users. My original hypothesis was that SGA initiators are more adherent and persistent to therapy based on that study I just talked about. Based on the known risk of hyperglycemia, perhaps patients have to pay more attention to their diabetes therapy and have closer monitoring. And these drugs have the most consistent clinical trial evidence for MDD and faster depression relief. Right, so here are my methods. So this is a retrospective cohort study using the Truven Market Scan commercial claims and encounters database from 2009 to 2015. I'm comparing two groups, so the SGA initiator group versus a non-SGA initiator group. And the SGA initiator cohort include oral formulations of second-generation antipsychotics, excluding clozapine, and my non-SGA comparator group includes bupropion, mirtazapine, tricyclic antidepressants, lithium, and thyroid hormone. So to be included in the study, patients had to have at least one prescription for cohort drug between January 1st, 2010 to December 30th, 2015. They had to be 18 to 64 years. During the 65 days pre-index period, they had to have a diagnosis of major depression, type 2 diabetes, as well as one prescription fill for SSRI, SNRI, and an oral anti-diabetic drug therapy. I'm restricting this to patients to have at least 365 days of continuous insurance coverage during the pre-index period. Now, patients with any of the following during the pre-index period will be excluded. Any prescription fill of a cohort drug, so they had to be new users. If they had clozapine, an injectable second-generation antipsychotic, or a first-generation antipsychotic, they were excluded because these drugs typically represent underlying psychosis. And then I'm also excluding patients with a host of psychosis and other mental health conditions that may be indicative of SGA use. Patients were excluded if they had any inpatient hospitalization within the 30 days prior to index date. And this is because this is immeasurable. Not that this is immeasurable. The inpatient medications are immeasurable. And then patients who initiated both on the same day. So I'm going to look at baseline characteristics, including demographics, antidepressant and anti-diabetic treatment history, healthcare resource utilization, comorbidities, and concomitant drug use. My primary outcome measures are adherence and persistence to oral antidiabetic drug therapy, comparing the two groups. For my primary outcome of adherence, I'm going to look at 10% or greater decline in OAD adherence during the 180 days post-index compared to the 180 days pre-index. And persistence is going to be evaluated through time to discontinuation of OAD therapy. So adherence to OAD is going to be calculated using proportional days covered, which you guys are familiar with. It's basically a ratio representing whether a patient was in possession of a drug or class of drugs during a defined measurement period. I'm going to look at the class-specific PDC, and what I mean by that is for patients who use more than one class of OAD drugs, I'm going to calculate their average, and I'm going to restrict analysis to patients to have at least 2 fills in the pre and post measurement period, and patients who have continuous insurance coverage. And this is because for PDC measurement, you really want to have at least 2 fills to make it meaningful. All right, so why am I looking at 180 days PDC? There's been a study in the Medicaid population where it has some reliable correlation with A1C compared to other measurement periods, as well as compared to NPR. And why 10% decline? This decline has been associated with a 0.1 increase in A1C, a 4% higher odds of hospitalizations, as well as about a 9 to 29% increase in annual healthcare expenditures. I'm also going to talk about some of the sensitivity analysis conducted where I measured adherence over 365 instead of 180 days, where I look at just the odds of adherence, so dichotomizing PDC to less than 0.8 versus 0.8 or greater. I looked at a 10% decline in adherence using the diabetes outclass rate, which has been suggested by HEDIS and recommended by the PQA. I looked at a 20% instead of a 10% decline, and then I also excluded any patients with any hospitalizations, again, due to that possible immeasurable time bias. Now for my persistence outcome, my primary persistence outcome is time to discontinuation using a permissible gap of 2 times the last day's supply. I follow patients until the first occurrence of the event, which is discontinuation of cohort drug class. I'm missing the one where you have discontinuation of oral anti-diabetic drug therapy, or discontinuation of cohort drug class, any switch or addition to alternative drug class, any gaps in insurance coverage, or to the end of the study period. Sensitivity analysis was conducted using different permissible gaps at 45, 60, and 90 days. For statistical analysis, I have descriptives. For modeling for my adherence outcome, I used multivariate logistic regression. And for persistence, I looked at the Kaplan-Meier curves and the Cox proportional hazards model. For covariate selection, I had some pre-specified forced covariates, which included demographics, adherence to OAD during the pre-index period, proxy of depression severity. There's a claims-based measure called the Massachusetts General Hospital Scale Antidepressant Version. Basically, it looks at past antidepressant use based on the duration used, number of fills, as well as any dose escalation. It's been calculated as a measure of depression severity using claims data. And for proxy of diabetes severity, I have adopted the Adopted Diabetes Complication Severity Index, which is another claims-based measure. It basically looks at the presence of 8 diabetic complications as a predictor of hospitalizations over a 4 years period. Other proxies of depression and diabetes severity include inpatient and outpatient hospitalizations and such. So for my multivariable regression models, I use a manual backward selection with a 10% change in estimate rule. SAS data was used for data management. All right, so let's come to the results, which is probably more of interest for you guys. So for the persistent cohort, I have 17,524 patients. They had to be OAD users at the time of index drug initiation. For the 180-day adherence, I have 8,664 patients, and this was really reduced because, again, I'm requiring them to have 2 fills pre and post, as well as continuous insurance coverage. And this was 8,311 patients in the 365-day adherence cohort. So let's look at the patient characteristics. I just want to point out some of the salient things I want you to notice. So the median age was 54 across. Most patients were between the ages of 40 and 64, so the older population. About 63-64% female.
Excuse me. Except for me, this whole movement silent. Whoa. 40 to 64 is an older population.
Well, older in my context. Okay, because I excluded anyone 65 and older. I did not say elderly population. I'm getting there too. Okay, I'm getting there too. All right. So the SGA group had more severe depression, as indicated by higher MGH-80 scores, higher number of previous antidepressant use. Adherence to SSRI and SNRI at baseline was very high. We're about 80% adherent and a median PDC of about 0.91, and it was equivalent between groups. More SGA initiators were concurrent users of an SSRI or SNRI, so they were adjunctive users, and I required them to have a 30-day gap between their index drug and the SSRI or SNRI. SGA initiators also were more likely to use psychotropics and had more psychiatric comorbidities. All right, there's no significant difference in diabetes severity. And if we look at diabetes drug history, it was quite similar across groups, and about 70% in both groups were OAD only users, so they did not use injectable or insulin. Now, there's actually a high proportion of 90 days fills for the last OAD fill prior index, about 42% and 43% in the persistence cohort, and about 33% in the adherence cohort. All right, the SGA group also had more psychiatric hospitalizations, more outpatient depressant visits, psychotherapy, and visits including a psychiatrist. Although there's more psychiatric hospitalizations in the SGA group, I do want to note that the rates were pretty low. So more than 95% of patients had no psychiatric hospitalization in the year prior. When we look at diabetes hospitalizations, the rates of diabetes hospitalizations was also very low in both groups, and a similar number of outpatient diabetes-related visits. Okay, the SGA group had higher pill burden and higher polypharmacy use. Co-payment for the index drug was higher among the SGA users, and co-payment for diabetes therapies in the past year was pretty similar. So let's look at adherence to oral anti-diabetic drug therapy. So if we look at the pre-index period, both within the 180 days prior and 365 days prior, there was actually no difference between groups. It was pretty high. If we look at the first box, the median PDC was 0.93 for both groups, and the proportion non-adherent was about 21%. During the post-index period, there's a higher proportion of non-adherent patients among the SGA users. You can't really tell from the median, but the Wisconsin rank sum test was significant. And there was a higher proportion of SGA initiators who had a 10% or greater decline. So let's look at, break it down a little bit and look at who had a decline, who had an increase, and who had 10% change. So we see, if we look at both 10% and 20% change, there's a higher proportion of SGA initiators with a 10% or greater decline. The increases weren't that different. And then a high proportion of both groups actually had less than 10% and less than 20% change. So looking at our analysis for the crude odds ratio, SGA initiators had about a 1.3 times higher odds of having a 10% or greater decline in PDC. And when we look at the adjusted analysis, SGA users had about a 1.3 to 1.4 times higher odds of having a 10% decline in adherence to OAD. Various sensitivity analyses that I talked about during my method section did not alter the results. All right, looking at persistence to oral anti-diabetic drug therapy, we see from the Kaplan-Meier curve that there's no significant differences. Okay, the log rank test was non-significant at 0.134. The median time to discontinuation was about 118 days for the SGA initiator group and 123 days for the non-SGA initiator group. The rate per 100 person years was about 27 and 25 for the SGA and non-SGA initiator group respectively. Crude hazards ratio was 1.07, and when we look at the adjusted hazards ratio, we see again there's no significant difference in persistence. Using alternative definitions of permissible gaps did not really make a difference in the significance or direction of our results. So I know that was a lot to go through. I just want to provide a brief summary. Contrary to my initial hypothesis, SGA initiation was associated with a 1.3 to 1.4 times higher odds of having a 10% or greater decline in adherence. There was, however, no significant difference in persistence to OAD therapy, and sensitivity analysis did not alter our results. So what does this all mean? So first I wanted to talk a little bit about the generalizable patient population. This was a relatively young, mostly female population. SGA initiators at baseline had more severe depression, psychiatric comorbidities, concurrent medications, and healthcare utilization. However, diabetes severity and past treatments were actually pretty similar between groups at baseline. And the patients, despite having both type 2 diabetes and comorbid MDD, they're probably still relatively healthy. This was an insured population. They had a low prevalence of psychiatric and diabetes hospitalizations. By having a new user cohort, that means that these patients must not have used alternative drug class in the year prior. And there's high baseline adherence to SSRI and SNRI and OAD pre-index. So if we look at the crude estimates, about 1 in 6 and 1 in 8 SGA and non-SGA initiators had a 10% decline, about 1 in 14 and 1 in 20 had a 20% decline over 6 months. And SGA initiators had a higher, 1.4 times higher odds of having a 10% or greater decline. And we know that multiple studies show that poor adherence to diabetes medications is associated with a host of poor clinical outcomes. So what does this mean for patients like JR? Right? Perhaps we should more closely monitor adherence to OAD therapy after initiation of these drugs, especially among SGA initiators. The good news is about 68 and 70% had almost no significant change in OAD adherence, and about 16 and 17% also had an increase. Does this mean that treatment possibly improved depression in these symptoms? There's a lot of unknowns. So what are actually the clinical implications of this decline? Could we predict patients with a decline? And we need to understand the reasons why a higher decline was seen among SGA users. So the study by itself does not tell us why patients had a decline. Could it be that SGAs were less effective or patients were more tolerant to these medications, which caused worsening depression and led to the higher rates of decline? And maybe in my other study results, I found a poor adherence and persistence to SGA therapy versus non-SGA therapy. Or could it be that SGA therapy was more effective And this improved depression led to better adherence to other self-care behaviors, for example, diet or exercise. And this made patients have a lower perceived need for OAD treatment. Therefore, they had a decline. All these are speculative and outside the scope of the current studies, but are avenues for future research. So let's go back to JR. Does JR start SGA like aripiprazole? Statistically, perhaps, about 1 in 8 outpatient depression visits end up with SGA. Should she start a drug? And I think the better way to answer this question is that really more research is needed to understand the downstream clinical impact of SGA initiation on diabetes outcomes. And what I can say is Dr. Smith should probably at least more closely monitor JR's glycemic control and her adherence to OAD medications if in fact she does start aripiprazole. So my next steps is currently in the current study I looked at diabetes self-care and adherence to anti-diabetic drug therapy. And my next steps are really looking at focusing on the downstream diabetes outcomes, which include diabetes-related hospitalizations and whether patients need intensification of anti-diabetic drug therapy. So more to come. So limitations, there's some unmeasured confounding. Even though I adjusted for a number of healthcare utilization, patient demographics, and diabetes and depression severity, there's unmeasured confounding, for example, social determinants of health. Perhaps there's different subtypes of depression. I don't know who the prescribing physician is, although I looked at who were the past physician visits that they had used during the prior year. There could be undocumented cognitive dysfunction or underlying prodromal psychiatric issues that's not documented in claims data. There's always a problem of misclassification of diagnosis. We all know that pharmacy dispensing data only serves as a proxy, but not actual adherence. And I didn't have laboratory data, so I was unable to directly examine the impact of SGA use on glycemic control. There are some strengths to this study. It's the first study that looks at OAD adherence with SGA therapy among patients with MDD and pre-existing diabetes. And this is important because a lot of these drugs are getting these indications, and all the new ones coming out are also seeking MDD indication. We know there's widespread use already. The outcome, I try to link it to something that's meaningful with clinical outcomes. And the outcome may be preventable. So perhaps an intervention, which is someone else's study, could prevent this decline or even predict patients who will have a decline. And it identifies area of future research. So I end with leaving you with this quote. This is by Dr. Thomas Willis, who is late 17th century. He is the English physician who's attributed to coining the term diabetes mellitus. And he attributed sadness or long sorrow, as likewise convulsions and other depressions and disorders of the animal spirits are used to generate or foment this morbid disposition, which he called diabetes. And we know this is not true, but it's been quite a while since then, but we haven't found a good way to co-treat these conditions. So, questions?